Good afternoon from sunny Toronto. My name is Naheed Jivraj, and I'm an intensivist and anesthesiologist at Sunnybrook Health Sciences Center. And I'm so excited to share a year-in review about the pharmacologic management of delirium and critically ill patients. I have no disclosures for the purposes of this presentation. Now, as many of you are aware, numerous studies have evaluated the effect of delirium on patient outcome. In a recent systematic review, delirium was identified in over 30% of critically ill patients with an increased risk of death, prolonged hospitalization, and most importantly, as you can see here from the graph on the right, the longer a patient spends delirious in your ICU, the increased likelihood of worse cognition globally and executive function at 3 and 12 months. Now, delirium itself has a variety of phenotypes affecting awareness, attention, and cognition, and it's fluctuating in nature. Now, delirium itself is largely invisible and missed almost 75% of the time. And the delirium we think of most often, hyperactive or agitated delirium, only accounts for about 1% of cases. In fact, the majority of delirium in the ICU is either hypoactive, about 35% of patients, or mixed, 64% of patients. As a result, the Society of Critical Care Medicine in 2018 released the PADIS guidelines, which suggested the use of non-benzodiazepine sedatives such as propofol or dexmedetomidine for sedation for patients who are critically ill, and emphasized the importance of a structured approach using the ICU Liberation ABCDEF bundle. And that I've outlined on the left-hand side of the screen to achieve these goals and reduce ICU-related delirium. And in one observational study that included about 15,000 patients from across the United States, this bundle was associated with improved clinical outcomes, whether that was mortality, coma, delirium, or otherwise. Now, of course, this is a retrospective study at risk of its associated biases, but points towards some improvement of patient outcome when we think holistically about delirium care. Nevertheless, the focus of today's presentation is on two key areas of this recommended bundle, the choice of sedation and delirium management. And so given the association between ICU-related delirium and negative clinical outcome, a significant body of research that has focused on pharmacotherapy has been built over the last 5 or 10 years. And they're really focused on two key questions. Number one, can delirium be prevented by some pharmacologic agent? Or two, if somebody is delirious, can we treat it and subsequently improve patient outcome? And the two drugs I'm going to focus on today are dexmedetomidine and haloperidol. And so the first trial I'm going to speak about is the MEND-2 trial. And in this trial, Pandhari Pandey and group asked the question, in mechanically ventilated patients with sepsis, does the use of dexmedetomidine compared with propofol for sedation improve the number of days alive without delirium or coma? In other words, can dexmedetomidine help reduce or prevent delirium? So they recruited about 438 patients in 13 centers across the US and randomized them, as I said, to dexmedetomidine or propofol. As you can see on the left-hand side of the screen here, they did not find that light sedation with dexmedetomidine reduced or prevented the primary outcome. There was approximately 8 days without delirium or coma in both groups. However, some key lessons can be taken away from this trial. First, I think clinically important cognitive dysfunction occurred in approximately 25% of patients in both groups at 6 months. And so this points to us so this result should remind us how important it is to think about longer-term outcomes for our patients. And importantly, what the risk of ICU care and ICU-related delirium might be for patients over the longer term. The second is that this study had excellent adherence to the ABCDE bundle. I think this is an impressive finding in and of itself, and maybe one of the driving forces between the lack of difference noted between the two groups. Importantly, as members of intensive care units across the country or across the world, it should give us hope that adherence to these bundles is possible and hopefully easy, and may lead to improved outcomes for our patients, and could be the focus of potential quality improvement initiatives as well. Finally, I think what this trial also shows us, and what is consistent across all the trials that I'll share with you today, is that continuous light sedation with only propofol or dexmedetomidine might be inadequate to manage patients' comfort and delirium. In fact, there was a high and frequent requirement for rescue medications across both groups. If we look at this, oh, sorry about that. If we look at the chart on the left here, you'll see that approximately 40% of patients in both groups required dexmedetomidine, and similarly, 40% of both patients in both groups required some further antipsychotic medication. And so the second trial I wanted to share with you today is the SPICE-3 trial, which was extensively reviewed by Dr. Burry in her wonderful presentation to the CCCF on the similar topic just a few years ago. Now, the SPICE-3 trial similarly assessed whether continuous sedation with dexmedetomidine compared with usual care would reduce 90-day mortality. They screened an impressive 30,000 patients and randomized about 4,000 of them to dexmedetomidine or usual care, which included propofol, midazolam, or other sedatives, with a primary outcome of 90 days. Now, as you'll see here from the table on the right, this trial also demonstrated no statistically significant difference in mortality between the two groups at 29% in each group. And additionally, that was consistent even in terms of longer-term outcomes of mortality at 180 days. Nevertheless, I think there were some important take-home messages from this trial as well. The first is that it reiterated this finding that it's very difficult to sedate somebody with one agent and one agent alone. In fact, nearly 64% of patients in the dexmedetomidine arm also received propofol. You can see that in the blue here. Similarly, almost 20%, or just shy of 20% of patients in both groups required some amount of midazolam in the first 14 days of their stay. The second part that was very interesting from this trial is there seemed to be some heterogeneity of treatment effect. In a Bayesian reanalysis of this trial data, there were some interesting findings. The first finding was that individuals over the age of 65 had some 97% probability of reduced mortality with dexmedetomidine. The second is they identified some clusters using advanced modeling methods, and one of the clusters that they identified seemed to be operative patients compared to non-operative patients. And in that cluster, there was a greater probability of dexmedetomidine, that is, those that were operative patients across all categories or broad categories of age, which with some 87% probability that dex was better than in operative patients than those who were not. So I guess this trial really showed us that maybe dexmedetomidine is not, from a statistical standpoint, likely to prevent delirium or mortality, but there might be some heterogeneity of treatment effect. The next drug I'd like to talk about is the antipsychotic haloperidol. First, Page and colleagues aimed to understand whether early treatment with haloperidol could prevent or reduce the time spent in delirium. They randomized around 142 patients to receive either placebo or standing haloperidol, irrespective of whether they were delirious or not. And as you can see on the graph on the right here, the two lines track very closely together with each other, demonstrating no difference in the number of days delirium-free or coma-free within the first 14 days. Unsurprisingly, haloperidol did reduce agitation, and there was some trend towards a decreased use of sedatives. So maybe haloperidol cannot prevent delirium. Maybe it can treat delirium and improve patient outcome. The Mind USA investigators asked this question. In delirious adults who are critically ill, does administering haloperidol, ziprasidone, or placebo, or or reduce the duration of delirium when compared to placebo. So they screened patients twice a day using the CAM-ICU checklist, and they randomized around 566 patients who were identified as having delirium using this checklist to receive either haloperidol, ziprasidone, or placebo. Median age in this trial was about 60, 44% of patients were female, and most interestingly is 10% of patients had hyperactive delirium and 90% of patients had hypoactive delirium. Their outcome of interest was the days alive without delirium and coma by day 14. So what did they find? Well, first, the trial demonstrated no statistically significant difference in their primary outcome. As you can see here, the number of days alive without delirium and coma were largely similar between the two groups. And again, the days with delirium were largely similar between the two groups. However, this trial still had some important key takeaways. The first is, I think, this trial more closely mimicked our patient population in the ICU. Indeed, a high portion of the patients had hypoactive delirium. However, many of us don't use antipsychotics to treat hypoactive delirium. And so maybe this subgroup or phenotype of delirium is less likely to benefit from antipsychotic medications compared to agitated, hyperactive, or hallucinogenic delirious patients. This study was very impressive for a number of reasons, but was really the first to directly compare typical and atypical antipsychotic medications against a placebo-controlled trial. The most recent trial, just published just shy of a year ago, was the AID-ICU trial. And the AID-ICU trial asked the question, in patients in the ICU with delirium, does haloperidol compared with placebo increase the number of days alive and out of hospital at 90 days? And so patients were screened twice daily, again for delirium, prior to enrollment in the trial, and they were randomized to receive haloperidol 2.5 milligrams 3 times a day if they were delirious, with additional doses as necessary, and titrated to effect versus placebo. And this trial looked slightly different from the Mind USA trial. First, the median age was slightly older at 70 years, slightly fewer female patients, 35%. 63% of patients were a medical admission rather than surgical, and a much higher percentage had hyperactive delirium, about 45%. So one of the other interesting components of this trial, as sort of replicated in many of the other trials that we've seen, is there was a high volume of rescue medication used in both groups, including propofol at around 15 to 17%, alpha agonists at close to 50% in both groups, benzodiazepines close to 30% in both groups, and open label antipsychotic agents about 13% in both groups. So what did they find? Well, they found no statistically significant difference between both groups with regards to the primary outcome, although there was some trend towards benefit, finding an adjusted mean difference of the primary outcome of days alive out of hospital of about 2.9 days in the haloperidol group. And there was maybe some absolute risk reduction in 90-day mortality of about 7 percentage points with haloperidol. It's important to take these results with caution, though, because data was missing for about 24 patients, and it would have only taken 4 patients to move this statistically significant mortality benefit to a statistically non-significant mortality difference. And so I guess after the Mind USA trial and the AID-ICU trial, has this door closed on pharmacotherapy and routine use of haloperidol for delirium? Well, I think there's a few things to think about here. The first is we still have so much to learn about delirium phenotypes and mechanisms. As we know, haloperidol, for example, is a dopamine antagonist, but perhaps not all delirium is a result of excess neurologic dopamine. And so despite the negative results in many of these trials, perhaps antipsychotics should just be used for particular subgroups of ICU patients, maybe those who are acutely agitated or suffering from delirium-related hallucinations or delusions rather than hypoactive delirium. I think the second thing we learned from our dexmedetomidine trials is maybe there's some heterogeneity of treatment effect. And I'm excited to see the results of the SPICE-4 trial, which will look at dexmedetomidine in older adults. Third, the next question we need to be asking ourselves is the management of delirium, should we be focusing on bundles or single interventions? And so, the MEN2 trial demonstrated to us that it's possible and feasible to have excellent adherence to these bundles. And so QI initiatives across the world should think about whether this is something that we need to focus on more closely and more broadly in each of our institutions. And finally is, choosing the right outcomes. Many critics of some of these trials felt that a single sedative agent may not be able to affect or change mortality. And so really picking the right outcome and patient-important outcome is something we need to think about as a research community for these patients and work with patients to identify these outcomes. So what's next? Well, first is a global need to identify and understand the pathophysiology of delirium. Second is improvement in compliance with protocolization. Third is an appreciation that an individual and probably personal approach to sedation management is critical. It's not a one-drug-fits-all strategy. As we saw from each of these studies, patients needed high volumes of other sedative agents that were probably tailored to their needs. Next is, of course, improved diagnosis and monitoring. In fact, many critics of some of these trials that did delirium assessments twice a day felt that these results might not be externally generalizable because in their ICU, they only assess delirium once a day. So perhaps improved diagnosis and monitoring will allow us to treat our patients better and faster. And this has been done, with the help of AI, with the help of EEG, and with the help of accelerometry in our Apple Watches, for example, or our smartwatches, for example. And then in terms of upcoming trials, there's many coming down the pipeline. The first, and many of these focus not only on pharmacotherapy, but on the organization and the structure of the ICU itself, including family support, such as family voices, partnering with families to diagnose and manage delirium, music or VR interventions, as well as the management of restraints, and of course, pharmacotherapy, whether with sleep medications, inhaled anesthetics, or dexmedetomidine in older adults. So this is an exciting time. Thank you so much for taking the time to listen to me. And I really hope that I get the opportunity to meet you in person at CCCF. Please do not hesitate to contact me with any questions. Thank you so much for your time.